Hi, folks. I'm Howard Lux.
I'm Jeff Berg.
We are the two boneheads, two older orthopods with a fair amount of experience, and we've been trying to bring it to you to improve your understanding of a lot of common orthopedic maladies. Today, we're going to talk about clavicle fractures. The clavicle is the collarbone. And Jeff, it starts where, ends where?
Yeah, so it's a long, thin bone from your sternum out to the side of your shoulder, and structurally, it kind of supports the shoulder, helps it hold together on the chest wall.
Right.
And
The clavicle, the shoulder doesn't have an attachment through the ball and socket joint. All right, our socket just sort of sits on the chest wall, so the clavicle has a really important function. Clavicle fractures. What's the cause of most of the fractures that you see?
well, for me, it's obviously a fall, but usually it's a biker. So, and bicycle.
Yep.
Somebody falling over their handlebars is probably the most common way that I see it. But we see them in other sports too, contact sports. Football would be a big one.
Yep.
And sometimes from a direct hit, like in lacrosse.
Agree. It's interesting. Jeff and I trained together many years ago, and the treatment pendulum for clavicle fractures has swung many times since we were resident. Everyone did fine without surgery, and then it swung thanks to comments out of Philadelphia to everyone needed surgery. And now it's starting to swing back the other direction towards non-surgical management, but there are indications for surgery. So how do we think through this? When do we start to consider surgery for clavicle fractures? Or who do we just treat in a sling?
Yeah, so for me, and so I agree with your point, things, move from one direction to the other. And the reason for that, I think, is because no treatment is perfect for all patients. And so that leads to part of when do you do one thing, when do you do another? And even that's not perfectly clear. But what we're trying to do is, I think, really obviously three things. You're trying to improve the patient's present status or quickly patients get back to work and activities. You're trying to prevent long-term problems. And so for me, there's some clear indications when I'll operate on a clavicle. Clearly, if the bone is sticking through the wound, through the skin, that needs an emergency surgery. Obviously, if the clavicle is pressing on some vital structures, your nerves or arteries in the area, that would need surgery. Those things are relatively rare, very rare, I'd probably say, depending on where it happens. And then there's other reasons, and that's where it gets a little murky. So one of the problems, as you know, Howard, that people can get with clavicle fractures is that the clavicle doesn't heal.
Right.
And if it doesn't heal, then people can have persistent pain there some of the time, but not all of the time. So even if the clavicle doesn't heal, some people have no symptoms.
Right.
So we're trying to spend some time figuring out, okay, which clavicle fractures might not heal. And there are some soft indications. If the pieces overlap 2 centimeters, if there's what we call comminution, multiple pieces, and even some groups of people, smokers, it turns out for some reason, women more than men. And so some people will operate when they see all these things, and some people will pull back. I'm relatively conservative unless I think that it's going to help the person in the short term. So there are some people who, what we found is if you operate on it, they feel better and are better more quickly. Some people can get back to work or their sports more quickly. And that sometimes leans me one way or the other in these folks. Because it turns out that a lot of patients, even if they go on to what we call non-union don't heal, they may do okay. And if you operate at that point, there's some evidence that they might not do as well. But even that's not perfectly clear.
So let's I think we should come back and revisit the incision and the troubles that we can have at the incision in a few, but let's take a few specifics. So let's say we have an 18-year-old, he's the quarterback or he's the pitcher, he's a pitcher for the high school, he's scouted, he has a centimeter and a half overlap on his clavicle shaft fracture. otherwise uncomplicated. And this is the dominant arm, or his right arm.
Yeah, I'm not operating on him. A couple things. One is the clavicle fracture. A very important thing to remember for most people. The clavicle fracture is the last bone to fuse, and it's part of the reason that men's shoulders get broader as they get older. So when a bone is still healing, or growing rather, then it has potential to do what we call remodel. It has better healing potential, and it can even fix itself to some degree. So you can allow in males at that age, you can allow some deformity or some abnormality, and it has a potential to correct itself. It has a good chance to heal.
Agreed.
And to your point, I think part of what you're trying to bring up is surgery has problems too. And in clavicle fracture, surgery can have some significant problems. I mean, you might want to comment on some of those, but and at some point we can. But to that answer, on that 18-year-old, I'd probably put him in a sling. I think I think he's going to feel fine in 2 weeks. He'll be thrown in about 4 weeks.
So a lot of people come to our websites because we have some active posts on this, and they see 2 centimeter overlap as a reason to consider surgery. So let's say you're a 53-year-old, non-dominant arm. Let's say it happens in you or me, non-dominant arm, not overhead athlete. Are we fixing this? Are we watching it for a little bit?
Yeah. So, well, that 2 centimeter mark. So, people use that 2 centimeter mark, but overlap of 2 centimeters, or 2 ends overlapping, doesn't mean that none of them are going to heal. A good number of them are going to heal. But if you look at groups, the group with overlapping by 2 centimeters didn't heal as much.
Right.
And
they may have a functional issue if they are an overhead athlete with that much overhead.
And they may have a functional issue. But for me, so it's tricky. So in our occupation, we need both our hands, and it's somewhat strenuous. And somebody could make the argument that you'll be able to work at a strenuous job quicker with surgery.
Right.
I probably myself would not have surgery for that, but I think you can make the argument, and that's where it gets a little murky. What would you do in that person? You operating on that person?
I don't think that I would operate on the non-dominant extremity of a middle-aged person who's not a triathlete, overhead athlete with 2.5 centimeters of overlap. I think I'm going to wait on that.
Now, what if he said to you, well, this is critical. I really, let's say he's a laborer and he's really working hard.
Sure. So, as you alluded to, there is some literature which shows that they might heal faster and sooner and get back to work earlier. However, as we were going to talk about, I guess we'll talk about now, we have the risks of surgery. All right. We're operating near a number of arteries and near your lung. So there's always a risk of injury. It's rare, but it does occur. There's always the risk that the bone is not going to heal, regardless of how well that we fix it. So in that case, the screws can break, the plate can come loose, and you'll need that out, and perhaps another surgery again. So fixing certain clavicle shaft fractures, and assuming all goes well, can return some people back to work more rapidly than non-surgical management. But do not dive into this thinking it is a surgery without risk.
Yeah, and the one you didn't mention, the one that I happen to see a number of times when patients from other doctors have come to me after having their clavicle fixed, is wound healing problems. There's not a lot of, between the metal on your clavicle and the skin is a couple millimeters. And all it takes is a little wound problem, and that thing opens up. You got an infection, you got problems, and you have a much bigger problem than you would have been in a sling. So you're right. It's not as clear cut as some would like it to believe. And I think, once again, it's trying to fit the treatment to the patient and not the patient to the treatment. And each case is a little individual.
That's a great point. As I like to say here when I teach the medical students, every injury has a personality. So the same injury can behave differently and require a different treatment approach depending on the individual who has suffered it. There is no surgery that, there is no problem that surgery cannot make worse. Certainly has its role and can improve healing. The pendulum is always swinging in orthopedics. It pays to get a few opinions with regards to your clavicle fracture. Perhaps in the future, we'll talk about distal clavicle fractures and proximal clavicle fractures, which are separate and different from these sort of mid-shaft fractures or in this, the center of the clavicle that we talked about today. Anything to add, Jeff?
I think that covers it.
All right. All right, folks. Take care.
How about now?